Hi, good morning. My name is Abdul. I am a surgical pathology fellow at the University of Pittsburgh Medical Center. I am interested in digital pathology. I'm interested in artificial intelligence and health policy. And joining me today is my friend Gaurav Sharma.
Yeah, hi everyone. Good to be talking to you, Abdul. I am a tech policy fellow, and my tech policy is rooted in artificial intelligence uh, within the EU AI Act. But we are also looking at the aspects of generative AI, and as it's a healthcare is a critical social impact sector, we should talk about it in light of everything that is happening around it. Yeah, thank you.
Yeah, yeah, definitely. So, starting off, I will give a little background about my interest in artificial intelligence and particularly in pathology, but also in medicine in general, at least in the United States. I started hearing about the use of digital pathology and artificial intelligence when I was a first year resident, and there was this fear that, oh, it's going to take away our jobs. Like basically, it was an existential problem for us at a certain point. So I started looking more into it because I wanted to know what is going on, and I've always been interested in newer technologies and how they affect with how they interface with human beings and our lives. Um, and since then, a lot has changed. Back in the day, we didn't have the large language models that we have today. We have ChatGPT 3. We now are coming up with ChatGPT 4. And we have the use of artificial intelligence, not only in pathology, but also we have apps that can track, if they can look at, for example, an EKG and tell you if it's proper rhythm or not. And there are other things that can be done. For example, Doximity is a platform that came up with something called Docs GPT, DOCS, and through which you can do something that a lot of doctors here find tedious, which is sending an appeal to an insurance provider, because the healthcare system that we live in, a lot of our issues dealing with patients come with when we prescribe someone something or we order a test and the insurance denies it. So in that case, doctor can actually go to DocsGPT and there is a basically a pre-filled form, or it can come up with a pre-filled form if you just tell it based on which company you're appealing it to. You can also DocsGPT. What it also can do is it can write a recommendation letter for a medical student. That is also something that a lot of doctors have to do sometimes because obviously it is important. And in pathology, we are because pathology is a lot about image analysis and looking at an image and basically making a diagnosis based on particular image or images. So uh, we have increasing uses of AI in that space as well, where it can help us do certain things that we still do, but some of them we find tedious. And I think that is sort of like a good use case for AI in pathology, although it is still in an infant stage and we are not there yet. And one of the things that concerns me and concerns a lot of other people is the regulatory environment. Like we don't have enough regulations on what artificial intelligence can do just yet. There was a case a few years ago that some at a large institution in New York, they shared their slides with an AI company, and that was a violation. There was some violation of HIPAA, which is very strong in the United States, the Privacy Act for patients. And the institution got into trouble. The head of that pathology department had to be like he was removed, and there was a lot of brouhaha about that. So there is still this uncertain atmosphere about what is going to happen with the regulations and what health policy can how can it be changed and what can emerge out of this thing. And that is why I'm talking to you, because you not only are talking about health policy in general but also about focusing it on the global south. So I would like to hear your thoughts.
Yes, I am in agreement of your. I mean, first you're a proper doctor, and I come from a doctor of looking at and talking to mostly PhDs who are researching this field. So I think healthcare is one of those critical topics based on in the global south, and I'm talking like not trying to put south as a context, but south in countries uh, like India, Indonesia, in Africa, who at least have an AI strategy in place. Some of them, most of them, some of them have data protection policies, but then there is a issue of healthcare decoupling itself from personal data and non-personal data. So in the global south, uh, the ideological mandate to use AI for social impact within the decision makers or the governance is to improve the health of the people, to have better primary uh, healthcare access, to undertake diagnostics of critical diseases in south like malaria, like tuberculosis, which are widespread. And this is coming from a good heart of the government, but because the level of problem itself is too intense, people are giving less, uh, sort of caring less about the legal aspects or regulatory aspects or data protection aspects, till the time they think that the benefits of AI can impact a larger population. So it's always like saying, okay, if we undertake diagnostics and if it is 90% accurate, we are still happy because we will be able to reach 90% of the vulnerable population. And even if 10 people have wrongly, we might have some sort of other means of mechanisms to do it. That is one aspect. The second aspect is the use of healthcare AI for better uh, healthcare services access, like as you mentioned, access to health insurance. And these are all dependent, like the case from India or the case from uh, you know uh, Kenya, or where basically you have heavy penetration of the mobile phones, is digitizing healthcare services so that somebody can take up the phone and say, okay, this is my identity. And digital health identities are a creation of things, which is also trying to incorporate the basic health parameters, which are personal data sets. So people will not only be asking your name, mobile number, and address, but they will might ask your blood group, what is your primary health condition, and somebody to say, okay, this is what you are suffering from, or something like a basic primary conduct. So I think these are the two fundamental aspects on healthcare where people are in the global south are thinking about it. You did mention generative AI, but I think I will come on to it in the next conversation as you go
Yeah, yeah. And I think I would say that having worked in some of my early education and practice was in Pakistan, which you can call as part of the global south. So I definitely think there are a lot of gaps that having a system, a basic infrastructure can help, because there is, especially in far-flung areas, because even in the U.S. there are a lot of places, rural places, where there are not available physicians for like hundreds of miles, which is just a function of geography. And similar is the case with places in India and Pakistan and some countries in Africa, which are really huge. So some initial healthcare or healthcare adjacent things can be done with if we use artificial intelligence. But I don't believe that it is there yet. The AI models that we have are not there yet. It's right now. We are still at the level of like WebMD level things. Like you type in a few symptoms that it'll tell you what it can possibly be. So it's right now, in my opinion, it's no better than just Googling your symptoms or going to WebMD and it telling you that you have cancer, even if you just have a headache. So there's definitely a false negative dilemma here that we have, or a false positive in some cases as well. So these are some things that I believe when you or people like you are making policies, they have to weigh the benefits as well as the downsides. And let's talk a little bit about generative AI, which I mentioned ChatGPT, which is one form of generative AI. So what are your thoughts about that?
Yeah, I mean, if you take the example of generative AI, there have been good cases in the past. In the past means so the healthcare system is you still require patients to give data, like even X-rays, simple, and analysis of that X-rays and some output. but this output is also consumed by the patient. So you will give advice back to the patient. Now, Mimic 4, or which is a very widespread example of X-ray data sets, had been decoupled from personal data, but had been very good at analyzing X-rays. So it is not only X-rays being put yes and no, but if you turn the X-ray upside down or you do it diagonally, the pictures or images are still being analyzed properly, and they give you an X-ray. But the foundation thing is you still need to collect those X-rays. So if in the global south, in say South Asia or in Africa, you need those 40,000, 50,000 people suffering from a same disease, their X-rays to be provided. Of course, there might be some AI algorithm which can work on analytics of this and then provide you. But the foundation of healthcare is you need those uh, X-rays or images in the first place. You cannot work on synthetic data of X-rays. Also, topographically, where you are collecting. Demographically, the symptoms and the physical appearance and of people living in Congo would be substantially different from people living in Sri Lanka. So if the same disease is being analyzed, you need localized data sets. So generative AI has still not reached a phase where this would be there. What generative AI has been able to deliver is, as you also highlighted, it can give you advisory assistance services that, okay, I have had a temperature of 97, and now after 3 hours I have this, I also have cough and cold. So it gives a good diagnostics, but it is an advisory tool where people can then say, okay, this is what I asked, this is what I'm feeling, and suggestive advisory, I would say, on
Yeah.
healthcare. I think that's where it is still holding itself up. Yeah.
Mm. Mm. Yeah, so I was recently at a conference just like 2 days ago, and a lot of the focus on the conference, and it is an international conference of pathologists from all over the world were there, and a lot of focus was on AI. And one of the talks that I found fascinating was that some people they compared their the slides that they had on a particular disease from people in the U.S., and then they had someone, a physician who also worked in Africa, so he got the same condition slides from Africa as well, and then they put it through an AI system to see if it could detect the disease. And since it had been trained on the American data set, it could not differentiate. It could not pick up the same disease in an African patient, which was discouraging. And obviously, I know that it needs a lot of work, but I completely agree with you with the need for more diversity in the data sets, and uh, the need to feed the AI, the generative AI that we have, or overall AI, to have a diverse set of patients, diverse set of cases, so that it is not mistaking one thing for another. And if you look at the news, like I would say about 5 to 6 years ago, there were some surveillance softwares that were being used in the U.S. and um, even on Facebook, there was something that there was an AI on Facebook that it would not recognize people who were darker toned. Like there were some things that it was doing that was some people would call it racist because it was discriminating against people with a darker skin. So uh, there is this famous phrase, garbage in, garbage out. I would also call it like a racism in, racism out. Like if someone is only looking at people of one race and then you point that device at people of different race, it would not be able to determine because it's a computer. It's only as good as the data you're providing it, and as good as the people who are responsible for providing that data.
Uh, yes, and that's where I think the whole conditionality of, say, I mean, we are 8 billion people, so 3 billion people don't have internet access. And people who also have internet access have limited access to the internet in a way that they're not having 4G services. So, as you rightly said, the global south and the global north divide in data sets is there, but still looking at the healthcare infrastructure requirements and so basically where healthcare data has been very effective, I mean, I'm little drifting, but is like DNA analysis of things, or drug discovery, because there is a lot data set which has already been provided. So say, having said, in and out of healthcare, data is still the king in AI for producing tangible, usable, effective results. Whereas in healthcare, on the primary side or secondary healthcare perspectives, where the need is okay, can I arrest malaria or tuberculosis in the first phase of its there? You need somebody on the field to reach that patient. Maybe you have a device, somebody coughs into it, it gives you an analysis, but you still need somebody to connect that last person to the last mile in that remote area, and
Mm,
that cannot be solved as a answer even through any generative AI till the time ChatGPT on sitting on a mobile phone can really tell you that what you are suffering from, and
mm,
that's really not possible in a sense. So we are in a way generative AI is being good in terms of showcasing what is all is possible, but then there is a far side of infrastructure, resources, excess, and yeah, all these things in the global south which are a little bit of a problem. Yeah, still.
yeah. Yeah, and as a parting thought, I would just say that I think the future is uncertain, but the future holds a lot of promise as well. There's obviously a lot of opportunity for people in India, in Pakistan, in China, in Africa, different countries of Africa to um, sort of come up with their own solutions, because I think this is the problem with the diversity in AI has to start at a local level. And sitting here, for example, me sitting here in the US, I cannot solve this problem for someone who is living in, for example, the Democratic Republic of Congo. So I believe that the future is local, for at least for when it comes to AI and using AI in healthcare policy, particularly.
Absolutely. I mean, I totally agree that the localized solution should come to phase, but the first phase of localized solution is integration of this AI into, say, things like WhatsApp, and if even WhatsApp use can really accelerate, tell me which are the nearest healthcare centers where the doctor is available, where the patients are. I think this integration is still happening, but again, as you rightly said, it is still happening in an English language. It
Hmm,
is not happening in, I don't know, Pashto or in Arabic, or in, I don't know, Kiswahili, or so
hmm,
these languages are still not in the generative AI component forming the brass tacks. Till
hmm,
the time it really goes to this language level continuity of incorporating vernacular languages and also and impacting real bottom of the pyramid, it will still remain more of a privileged tool to be used by maybe English or Mandarin speaking people, because
hmm.
they still have this big data sets to hold on. So this is my parking thought, but thank you for your time, and yeah,
Yeah.
wish you well. Yeah.
Yeah, thank you very much. Yeah, yeah, and you too,
No.
because this is obviously we are sitting at the cusp of a lot of discoveries and changes coming to artificial intelligence and to our own worlds. And 10 years from now, if you look back at this conversation, I'm sure there will be a lot that we have to say about. And I think I wanted to talk to you not just for the sake of now, but also to set a record for posterity, so that in case we still have YouTube and internet 10 years from now, we can look at this and see if we were right or we were wrong. So thank you very much, Gaurav.
No, thanks a lot, Abdul. Take care of yourself. Yeah.
Yeah,
Bye.
thank you.
Bye
Bye.
bye.